We appreciate our special guests. So, we have the,
We'll start with public comment. Is there anyone who is wanting to offer public comments this morning?
there's not. Okay, so, this month is our long-term care residences spotlight. And I know we had a lively discussion at our last, call meeting. We also had a chance to, update the board. Charlie and I updated the board on the age-friendly Arlington plan. And we had a good discussion with Libby and Susan. They're very interested and had good suggestions about collaborating with other housing and long-term care providers, as well as working with our existing providers. And that they are interested in the issue and to keep them updated. So I'll hand it over to Charlie to address any provide any updates or spotlight issues that the long-term care committee would like to provide, as well as my meeting.
I think, our initial phase of the age-friendly plan is all educational. We have a really, I think, exciting vision of what nursing homes should be like in the long run, and I think Arlington has opportunities currently and down the road to move in the direction of what we call the small household model, and it's really we just want people to become aware of it right now. That's been our main focus.
Okay. Any other things you want to bring up?
I don't think so. It's too early in the mornings for me,
Yeah, please go ahead.
Thank you, Charlie. It's good to be here, everyone. Good morning. At the Long-Term Care Residents Committee meeting on Thursday, we talked about looking at getting back into the community settings for our meetings. Once upon a time, that actually happened. And so because of the age-friendly priorities, thought it'd be good to have every other meeting be in a long-term care residence. We want to start off with vitality. And the reason being for vitality is I learned, and I shared this with the committee, that they are an employer of individuals with developmental disabilities. And so we had an employment summit back in the spring, and they had a panel workshop of one of our individuals with developmental disabilities speak to his wonderful experience at Vitality, and he is paid and he loves it. And so that really sparked some interest with bridging kind of the disability world and the aging world, and knowing that there are opportunities for even other communities, because there are hard to fill positions, but for communities to think, individuals with developmental disabilities who employment is a value, it's a priority. Let's see how we can foster this. So I think Vitality is a perfect host, and this particular individual wants to share his journey with the Long-Term Care Residents Committee. So,
Well, thank you on that. Yeah, I think it's very important that we're doing the community outreach, because I always like to think of it as a three-legged stool, commission on aging. And so I think of COA as collaboration, outreach, and advocacy.
we need a round of applause. I love that.
Yeah, and so it's a three-legged stool, so we can advocate, but we also have to collaborate and be in the community. And the outreach to, as Joan and Catalina and also Peggy are doing. So yeah, all those things are important, because so I really appreciate the long-term care committee doing that, because we need to get the community's input. I know we're working on the councils, and all those things are great things. So
Yes.
thank you for doing it.
Your community advisory councils is something we really want to revive.
Yeah. Good.
Starting with Cherrydale, so.
Exactly.
We're really focused on, we're very invested and hopefully to do a kickoff information meeting for those interested members. Charlie identified himself as interested in representing the committee for the Cherrydale Community Advisory. We also have Kristen, who is the new liaison for
Right.
Cherrydale. So she's
Thank you.
invested in being a community advisory member. And then we have Martha Villanegro Santiago. Is she on? Okay, she's also interested and she's a former commissioner, as you know.
Yes.
So I think we're gonna have a solid interest to get started. So I'm really excited. And as I mentioned a couple of weeks ago, I'm very invested in seeing this come to fruition.
Thank you, Linda. And of course, that's a great segue because we have our special guest. So thank you, Tremaine, for coming, and I appreciate your interacting and collaborating with us. And I'm going to turn the floor over to you unless long-term care wants to make any introductions.
I just want to say, I'm glad to see Tremaine. Tremaine and I have had several conversations over the past year, and then leading up to this presentation. So he's been the administrator for Cherrydale for a year and a half.
Yeah,
Oh.
over,
A little over, okay.
on 2 years in January.
Oh, 2 years, and that's considered long-term for an administrator. You say sadly, but actually it's a strength. And so I'm gonna turn it over to Tremaine to introduce himself and to share with you about Cherrydale and also open it up for questions.
All right. So before I get started, I do want to introduce Manny. Today is actually Manny's first day. He's assistant administrator at Cherrydale, so I thought it'd be good for him to come along. So we both work nice together.
Thank
Sure thing. So I'm originally from North Carolina. I went down to graduate UNC Chapel Hill, and then I received my master's of social work at Howard University. And once I transitioned from there, I worked in nonprofit, so others might eat, in Washington DC, and worked with individuals that have severe mental illnesses. And then I transitioned over to transitional housing for pretty much residents that was in a 90-day inpatient program. And then we worked on obtaining housing and then also employment for them within a 90-day window, which was a big challenge, but we had a lot of success there. And I had a buddy of mine that was a graduate school, kept bugging me for more long-term care, and I really loved the health benefits of nonprofit and the passion work. And I finally got my foot in the door, and my mind was just blown that there's this other world that was out there. And I was originally on the steel floor, so I had about 60 patients coming in, learning the process, trying to coordinate discharges. Actually worked with Kristen back in Regency, with RAC program. So I did that for a while, and then I transitioned between Maryland and Virginia several times. And then from there, I did my administrative training program in Maryland, and probably in 2017, I started in 2016, I started seeing some gaps in some areas of improvement that can happen in nursing homes. So I, as a social worker, really, you're at the mercy of whoever your administrator is. And there's some that are really awesome and really involved, and there's some that are about numbers, and you have less of a role as a social worker. So that was really my segue. I wanted to become an administrator because I wanted to have a great impact on the quality of care that residents were receiving. After that, I worked in Illinois as an administrator. I worked in Maryland as an administrator, and I'm in Virginia. So I've been, as I mentioned earlier, coming up on 2 years in January. One of the recurring questions are, I'm surprised that you're still there. I just smile, and at first, I couldn't understand the question, and I really enjoy what I do. It is a very challenging job and challenging role. But part of my why is I want to have a great impact and influence on overall patient care. And what does that look like? Quality of life. a resident, is either in a private room or they're in a semi-private room, and that's their entire house. And sometimes people lose sight of that, and you transition from, 2-bedroom house or whatever your situation were, and then going to a nursing home, it's a huge transition. So I want to create a home-like environment and work on the psychosocial impact. There's a big transition, and I feel that with being a social worker in transition, and I come with a different lens than some administrators, and each one has their own pathway. So it's not speaking negatively to any of those. And then my goal has always been to work in a facility that I felt comfortable with, my level being in, and it's something that you hear quite often, but that's true to my core. When I stepped before the board for my first license, that was my why. I have a grandmother that's in North Carolina. She's in a long-term care facility. She's been there for about 6 years, and my mother was a caretaker for a really long time. And she could not take care of her anymore, and I made a transition to putting her into a nursing home. So I've been kind of that mediator between grandson and mom. That's actually what the facility can do, and that's sometimes a hard a mediator to be, because sometimes mom is upset that there's something that she wants to have happen or happen for her that it's not something that can happen. So it's kind of how I got to long-term care and where I'm at now. So I've been enjoying my time at Cherrydale. It is very challenging. It's also very rewarding. But I feel like my purpose is to serve and to help this population that I'm working with. So I have a pretty short presentation. I did get an email from Mamuna with some questions. So I left a lot of room for questions. Figured it's been a long time since a representative's been here, and there's some questions that I want to ask directly, and then we can kind of work from there.
Thank you.
So Cherrydale is a 210-bed facility. We have 46 private rooms. We have 2,000 square foot rehab gym. We do have physicians and also nurse practitioners on site. One of the fortunate things for us is we have 2 nurse practitioners that's there Monday through Friday. And then we also have a on-call provider that we can use too, once there isn't a physician in-house. So that helps with continuity of care and really get not having to delay any type of patient care or changes that may occur. We are introducing a new trach program that would be at Cherrydale. We're still in the works of trying to get a dialysis unit going there, but the trach program is something that's communicating with Virginia Hospital Center and a few others is definitely a need in the community, and we want to continue trying to service the community. With the,
can you, would you say tricks?
oh, sorry,
What?
trach.
Tricky.
Oh,
Sorry,
tricks,
sorry.
okay, I didn't know what that was, okay, thank you.
If I talk too fast, just tell me to slow down.
Okay, appreciate it.
I don't have that part of the Southern accent anymore. But it's a trach program that
Got
will be starting, and it'll be on my 5th floor. And it'll be essentially for long-term care. So Virginia Hospital Center, I know where Alexandria Hospital, I know where Fair Oaks and MedStar Georgetown are our primary hospitals that we service, with predominantly of our residents coming from Virginia Hospital Center. We accept a wide array of insurances: Medicare, Medicaid, private, Anthem, Aetna, Humana, United Healthcare. We just started a Kaiser contract, so that'll be something that'll be helpful in the community too, which Kaiser having their own case managers and the discharge planning process. They're very involved in that. So that process starts 7 days before residents going home. So going through their equipment and home health providers and those type of things. I think that's a real big benefit. So the model that we work from our rehabilitation, and the rehabilitation is for short-term and long-term care patients. So common misconception is residents that come into a facility for rehab and go back home, they're the only ones that receive extensive therapy services. But this is also long-term care patients too, someone that may go to the hospital, or someone that may have a change of condition They may have been ambulating with a walker and now they are having some gait issues. We can evaluate them for therapy services to try to improve their ability and mobility within the facility. But the first step is a clinical assessment, and that's just looking at what's the patient's prior baseline. What were they doing in the community before they came to the facility? And then that transitions to a jumpstart meeting where all the team members meet with the resident, family therapist. We look at what the resident goals are, and then we create a service plan for success for return to the community or maximizing their potential within the facility. The acceleration phase is when we go to the critical threshold, and that's where a patient may self-initiate a discharge, or they may be ready to transition back home, and they've been to the facility and they've been there for, let's say, 14 days, and then they miss the way they prepare their foods, or they miss their nook in the corner where they read and have those activities. That's where we kind of collaborate and ensure that there's a safe plan for them to transition back home, because the goal is for a resident to remain in the community and not readmit to the hospital. Lots of studies show within the first 30 days, anyone that's readmitted back to the hospital, they decondition, they have a loss of endurance, and they return back to a nursing home from there. They're most likely going to have a longer stay and a greater chance of them remaining in the facility as a long-term care patient. So we try to eliminate that process as best that we can. So just looking at the kind of our makeup of our residents, our average age is 73. We have our youngest patient at 40 and our oldest at 102. And we have about right now, excuse me, about 10 patients within the 40 to 50 range. And I feel like since I've been in long-term care since 2016, it seems that number is going up, more increasing.
Could you give an idea of what ballpark of how long a typical resident stays there? Is it 30 days or 3 years? Or?
For a short-term, a ballpark for a short-term patient, I think right now our average length of stay is around 28 days. Long-term care, I don't have a ballpark figure for that, because consider long-term care as anyone 100 days or older in a facility, and someone can be there for 20 years and some can be there for 5 years. Or we have a resident that's been there. She was at our facility for about three years, and then she ended up going, actually improving, going to independent living with her case manager back into the community. This was about 4 months ago.
Okay.
So we do have residents that transition back into the community too. We're about 53% men, 47% women. And then our racial demographics: African American, white, Asian, Spanish. And I don't have exact data because I do need to have some updates in there, but right now I think it's about 40%. That's about 38% African American and about 40% white. Asian, I believe, is about 7%. So, and then we have a very diverse religion within the facility: Christian, Catholics, Jewish, Methodist, Baptist, Muslim, Jehovah's Witness. We have a pretty sensitive religion within the community. So the residents in our facility, they are no different than you and I in this room. We're all one accident, an injury, an illness, from being into an assisted living, or being disabled, or being in a nursing home. And that's where some of our patients that are in the lower age group. We have someone, since I've been there, I think she was about 24, 25, was in a really bad accident, had an amputation, had some other issue that was going on, and she was in the facility. She ended up discharging back to the community. But it's not just 65 and older, so it's a wide array. And the challenge within that is you have someone that's 25 and you have someone that's 75 or 73, where our average. What's the commonality there? What type of activity programming? What type of modernization of activities and communication? Allow someone to still be themselves with so much change that's going on in nursing home, or so much change in their life. So that's one of the things that we try to do a good job on. But that is a challenge where you have such a wide difference in age within the facility. We had some resident that was previously homeless. We had a resident that attempted suicide and shot herself in the head. But she comes to the facility. She has a knock joke for you. She's smiling. She's laughing. Her great appreciation that she has. But she's a resident that she can always knock on my door and give me a joke of the day. But and then we have residents also that have no community support. They have no family. We are their family, and that's really tough, you know. And I try to make rounds as much as possible to see as many residents as possible each day. I have my group that sits out front when I'm leaving, and they call me boss man. Had a resident, I had a couple in the facility, and they used to have an acronym for me, and it was our little inside joke when I left each day and I come in the morning. So it's, you know, just putting a smile on someone's face is very impactful. And, you know, I had surgery on my ACL back in 2012, and I was a very active person, and I was on a couch and couldn't do a lot of things, and it was a very difficult and challenging time for me. And I still can't imagine being in a nursing home, and I was around 25 at the time, and not being able to, you know, go out across the street to the store, you know, go through a drive-through, go hang out with some friends, and some of the things that we take for granted. So those are some of the things that keep me going as well. But we're going to be able to provide support for each of the residents that are there. And the residents that don't have family, you know, we want to make sure that they have a buddy system where they have activities, or when we do our rounds each day, each leadership member is assigned to a room. They go in, see how the residents doing, check on their well-being, and if there's any concerns, anything like that, then we'll come back to our meeting and try to devise a plan, whether we're trying to get psych service involved, we're trying to get them out of their room. I think one of the things that happened with COVID is, you know, March of 2020, you know, everyone had to stay in their rooms, and you do that for several years. It's very hard to, you know, you build habits. It's very hard to break it at the same time. So, you know, one of the things we try to do is someone that's been in their room for a while, just have them people watch. You're not engaging, but the more you interact, the more you hang out, the more it becomes more normal. So I'll go through some of our leadership team. Tina Malave, that's the director of nursing. She's been at Cherrydale for about 4.5 months now. Nedja Habib, she's our infection preventionist. I'm sorry, I should go back to the director of nursing. So she's responsible for the nursing department, which is a large department in the facility. Education, training, reviewing their clinicals, holding you guys, nurse managers accountable for their units.
And how many are in that department?
In nursing, at leadership.
No, well, how large is her department that she supervises?
Oh, it's about 105. And you have to think about, you know, we have 3 shifts, and then we also have 4 patient floor levels. So our shifts are 8-hour shifts, so 7 a.m. to 3 p.m., 3 p.m. to 11 p.m., 11 p.m. to 7 a.m. So you take 4 floors, that's a lot of staff.
That's a lot of stuff, yeah.
And that's not including like the support staff, like the unit manager, assistant director of nursing, the unit managers, staff development coordinator. So Andrew Mensah, he's our staff development coordinator. So he does a lot of education, a lot of training throughout the facility. And he's a huge, when we identify different issues in the building, he's the one that spearheads the training. So we do it all together, but he's the lead person on those. We have Nedra Habib. She's our infection preventionist. So she's responsible for infection control. That's looking at antibiotics, looking at like COVID testing, trying to set up COVID clinics, vaccinations, immunization, infections, tracking, and ensuring that we have the appropriate signage and staff are following through what the actual contact precaution, like droplet precaution, where they have to wear a mask or N95 or a gown or enhanced barrier protection, where if you have a Foley, you're set on that. And if you're not providing patient care, you don't have to You don't have to wear a gown or anything like that. Come in for, well-being or need a cup of water, whatever those things are, you wouldn't need a gown. But if you're changing the patient, doing patient care, then that would need. So that's something that started out last October, was one of the regulatory changes.
And that person has what credentials? That a doctor or nurse?
RN,
RN?
yes. Taja Lee, she's our director of admissions. She was at Cherrydale. I think she left Cherrydale back in 2019, and she's come back. And one of my families told me that we had a couple of team members come back and say, "Yeah, that's we always leave the front porch light on." So it's like your way to come back home. So that's what I will always use that now. Darlene Hobson, she's our director of rehab. She's been in Cherrydale for a very long time. She's a staple. She's in every department. She's a speech therapist by trade, but she's really one of the ones that are cornerstone of the team. April West, she's the director of discharge planning. Garrett Collier is the human resources director. Jessica Martinez, she's our business office manager. Teresa Garcia, she's our recreation director. Stephen Brinkman is our maintenance director. That comes to work in a three-piece suit and works all day. He gets a lot of stuff done. Larry Denson's our medical records. Anthony Taylor is our central supply. Brookie Bell is our environmental service director, responsible for the upkeep of the building. And then Raymond Kumar is the director manager.
Did you mention medical director?
Dr. Bahiri, Amir Bahiri. So my vision at Cherrydale is to continue developing my leadership team. Since I've been there, had 100% turnover.
10%.
100%.
100%. Any factors that, is it pay or burnout?
Well, some resigned, like when I accepted the job and I was starting, you're aware, or they're informed there's a new administrator coming. So sometimes people look for different jobs, so they don't know what type of person coming in. So I lost several team members before I got into the door. So I lost the discharge planning director, Sahar, Blanca, the business office manager. Jessica Martinez, who's my assistant business office. She's my business office manager when I first got there. She was my assistant and she was working on her notes at that time. So I was able to get her back into the building. And then a couple managers. So some is what I mentioned, and then some transition because of what my standard was. And I have lots of questions. I'm very nosy, ask lots of questions, very involved, and you're hired to do a job. So there's a combination of why there's transition, and some just isn't a good fit also. So try to talk about like culture of the building. Culture is really, really important. So that is something that I'm working on within the building. But hope that answered your question.
Yes, Tracy.
Next vision is hiring quality team members.
So what is your current staffing ratio to patients or residents?
So it depends on the floor. So like our second floor has 32 residents, the maximum 32. Our third floor is maximum 60, fourth floor maximum 60, and then our fifth floor maximum 58. So the staffing is also comprised of the acuity of the floors too. So for instance, our fifth floor has 58 residents and our fourth floor has 60. And numerically, they're very similar, but that floor also has some skilled patients, it also has some long-term care patients, some patients that have some mental diagnoses, so it requires a lot more manpower than say the fourth floor. And but it's not to say that the fourth floor doesn't need help also, but we try to balance that out between what the census is, what the floor is. We were at around 200 right now. But about a week ago, we were down in at 180. So the staffing model changed based on that. So we try to keep 2 nurses on the 2nd floor, 3 on the 3rd, 3 on the 4th, 3 on the 5th. But that changed based on the census, and someone calls out, we try to restructure staff to also balance out the floors as well. Improving resident clinical outcomes is one of my goals, and improving resident activity. So kind of touched on that earlier in trying to have more resident programming. So we have evening programming. When I first got to Cherrydale, we didn't have much evening programming, so we started having it twice a week, and we started increasing it a little more because activity doesn't start just because it's 4:30 or it's 5 o'clock. Needs to be some evening programming as well. Then my vision is for Cherrydale to become a premier facility in Arlington and also in Northern Virginia. So I know Cherrydale was a 5-star facility, back in the day or several years back. And that's a goal that I want to work with Cherrydale, getting back to. And then speaking of like the overall, what the vision is for a 5-star facility, and overall, we're currently a 2-star facility. We have 1-star for health inspections. And our last annual survey was August of 2022. So they go through 3 survey cycles that has a big impact on what your health survey is. And COVID was a big disruptor for a lot of surveys. So there's some facilities that have not had a survey in 3 years. And I know that they are get a lot of hiring at the state level for surveyors. So they get a lot of the surveys caught up. So we're in that window, and generally the survey comes between 9 and 12 months each year. And we're approaching 2 years at this point. Staffing is another metric. So we're 2 stars there. Staffing takes into account your CNAs, your LPN, your RN, and turnover also. And then there's a new component of administrative turnover also. So the more turnover you do have, the more it has an impact on what your staffing is. So we have had significant improvement in our staffing at Cherrydale. We also utilize the agency also. So areas that we may not have enough staff while we're still hiring, we utilize the agency also. We try to utilize the same agency members just to maintain continuity of care. And then the last metric that's in that 5-star rating is quality measures. Quality measures, sorry. Quality measures were 5-star. And what quality measures consist of is the type of care that you provide. So it takes into account the short-term, short stay, and long stay. And the short stay is less than 100 days. The long stay is greater than 100 days. And it's, falls based on the state average. It has falls with injury, UTIs, psychotropic medications, a worsening or wounds that are improving. So it takes account of all of that. So although, we are a 2-star facility, we do have 5-star quality measure, which talks about the care. But the goal is to increase that overall star rating and improving the staffing, hiring, reducing the turnover. The turnover, is part of it because trying to get the right fit and the right characters in the building also, because we want to make sure that we do provide the appropriate care. So the turnover can be a little deceptive, just based on what's happening. I know when I first got to Cherrydale, the staffing was at a 1-star, and that was because there was a glitch with the time clock. So each employee has an employee identification number. There was a software issue, so they had to go to a different time posting system. That caused everyone to have a new employee identification number. So it looked like Cherrydale had 100% turnover, just based on the same employees, but a new identification employee identification number. So that's the goal. Is the goal to get 5 stars, and that's going to be continuing education, having good practices, having lots of training, lots of education, and lots of accountability as well. And not just what we'll continue to do. And I think I mentioned 100% turnover in the beginning for my leadership team, almost 100%. But we also have brought on some really good, strong people too. That's going to help get us in the direction that I'd like us to head to. So,
So great, yeah. Go ahead. Thank you for that tremendous presentation. And questions?
Yes.
Yes.
So
Josh.
can you talk to like admission criteria? Because there's always some challenging patient situations, like some trigger level 2, which is mental health, right? And then some have other challenges, like what is their discharge post recovery? So can you talk a little bit about that? Like what goes into the admission screening?
sure. So, I guess we get a breakdown of what our actual census is or metrics. So we are around 200, and we have about 138 long-term care patients. And our skill mix today is 36. I have to take a look at that. That's comprised of Medicare Part A and then any managed insurance products. And then, excuse me, you have some patients that are private pay, and then hospice is separate also, so that makes up the total number. Excuse me. All right, the question again, I'm sorry.
Like, what is your screening
Oh.
criteria for admission?
So I say that with our long-term care, so our second floor is set up as all private suites, and that's just for someone that's coming for rehab and they're going back home. And then or they're coming, their plan is for them to go back home and then they are going to stay into the facility because they don't have enough support at home. It's not safe for them to return back to the community. It's not enough resources. And then they're transitioned to long-term care. So we look at what the makeup of the facility is. So you look at what their diagnosis, what caused them to go into the hospital. And then the ultimate decision is, can we handle their care in the facility safely? So we look at those parameters, and then we also look at insurance. Insurance is also very important features. So we look at insurance and look at the clinical capability. And then if we're able to work with that patient and provide the care for them, then we'll go ahead and bring them to the facility. And then if the patient maybe we have, right now we have 10 rooms available, and based on those rooms, if we're bringing someone in, we want to look at their total care and then also look at who we have in the facility that's in our room that's by themselves. So if they're going to combine, the roommates want to make sure that it's going to be safe for both those residents to be in the room at the same time.
Chuck.
Well, one specific point of data and then a general question. Do you know the percentage of Medicaid residents right now?
So I know the MOU is 60%. I believe we're about 66%.
Okay, my general question though is, are there any, what has been your experience in terms of what support or challenges there are in working for a system like Medical Facilities of America? You're part of a chain, right?
MFA is a consulting and charity is its own entity. So MFA consults for the facility. I love work for MFA. And I say that because I work for a different organization for a extended period of time, and like the amount of support that you receive. For example, for my recreation director, there's someone that helps with that from our regional level and consults with that person. That recreation director also reach out to different facilities that have different like programming. There's 2 other facilities that have a trait program. So what does the resident programming look like for a trait patient? So it's not, you don't have to reinvent the wheel. There are some resources where you can connect with other peers that can also help with coordination of care.
It's good to hear.
So MFA, so just to clarify, is not the owner of Cherrydale, they're a consultant that you work with?
So Cheerios is considered its own entity.
Okay, so you're privately owned, yeah.
And
And the MFA is a consultant, okay. I also had a question about, you mentioned that the number of residents, the 40 to 50 year age range are increasing. Is that primarily because of mental illness, because of physical disabilities? What are you seeing mostly in that age range?
Okay. As far as like the evidence base behind it, I don't have the data to support it, but just from my experience, It's mostly like, residents don't have, support and they're having like some catastrophic, like, the young lady, was in an automobile accident and, she was, confined to a wheelchair, but she also had limitations that she couldn't transfer and she couldn't do a lot of different things. And then, her home that she was in is not set up, for a wheelchair. It's not accessible. You have stairs to go in. So there's a lot of factors that go into it. Losing your job while you're in that process, and you have no source of income. What does that look like for you to thrive into the community? So I think a lot of those factors come into it. Mental health does come into that as well. And then when you combine a lot of those together, then it's a perfect storm for, not being able to survive in the community independently.
Can I ask one further
Yeah, please.
clarification on the ownership? Yeah, when you go on the CMS page, under ownership, it lists all sorts of different variations of MFA. And so I'm kind of confused, who really does own Cherrydale then? I'm confused at who's the actual owner is.
Okay. So trying to figure out how to.
Is it a partnership, its own partnership, the corporation, the partnership?
So then I mean, some parts of MFA are consulting and other parts do other business things. Well, makes sense.
Great. Also, could you talk a little bit about the expansion and, what are the visions or just general overview? Because that was a part of what we discussed.
Okay. So the trade program, we're looking at approximately 20 patients, 22 patients in all semi-private rooms. And so that's more like looking at what's happening in the hospital than what's hard to place. So someone with a trach, there are limited places that you're able to admit a patient with a trach to. And then when you do have the resources for a trach program, those places are generally full. So it's just a need that we saw that in the community and explored the opportunity to see if we can do that at Cherrydale and help support the community with trach needs.
So you're building an addition to the.
No, it's still like
Within the building.
yes, it's within the building. It's a standard room. It's just another clinical capability that will be.
I thought there was a physical expansion. Is that not true? Or Yeah.
Right, you're right, that was part of the.
is there gonna be an expansion? I understood that the lease is being extended and there's a new building or additional buildings. Do you know, could you give us any idea what that is?
Has that come your way yet? Because it's still under
Yeah. maybe not.
negotiation. And sometimes what you find, it hasn't come the way of
Right.
the administrator yet. As a, kind of.
Yeah,
a
that's
That's
what
why
we're.
we're 5 to 10, 20.
Right.
Here's to you, right?
Yeah.
Yeah, that's what we're trying to see if you could shed some light for us, but if not, that's fine.
Yeah, I don't know if that's like another floor or it's in the building.
That
Staff.
is still up in
Yeah.
Yeah, okay.
the county.
Thank you, Jermaine.
Okay, sorry.
Okay, Michael.
Since we're not an oversight board, we are an advisory board. What can we do to help you and your staff become a five-star facility?
That's a good question. I think, one, getting that reestablished, so like the monthly meetings, with liaison, I'll be meeting with, Kristen and going over some of the, what are some of the shortcomings, some of the gaps, and being able to have, like routine meetings where, I'm not sure, it might have been Hannah, the last administrator that had a meeting with the liaison. And since that's happened, there's been so many things that's dropped off. And I think just having like that recurring meeting where we can have dialogue on like, what are our shortcomings or, this is the challenge that we're having, or this is where we can have like more education or volunteers, different things like that. I think just having those monthly meetings to help close that gap because it just hasn't been the consistency. And my member's been doing a really good job of updating me on, kind of how it works with Cherrydale and the MOU and the committee as well. So I think getting that reestablished should go a long ways. But I think the number one thing is like volunteers always goes a long way. We have a lot of staff in our building, in our activity department, but just having volunteers. I know, one of the things, I haven't followed back up yet was, the elections coming up and, having like a, voter drive. That type of engagement helps, bring people to the facility and see what the facility, looks like. And, it's one thing to see it on, Google or on the internet, but it's another thing to come in and actually see like what's actually happening, what's going on. So I think volunteers is probably one of the,
Linda.
Are you actually a voting site?
no.
No, so your residents have to be either vote by absentee ballot or be taken?
Yeah, I'll be working with, my recreation director and also my discharge planner, on getting a system for residents so they are able to vote.
So just to follow up on that, Tremaine, though, but real quick, push what you want, what you need. Because this is a collaboration, right? We're not here to question you and how you all operate, do what we do. What can we do to help you and serve the residents of the county? That's powerful. So if you have needs and ideas, bring it to us, please.
Thank you.
Yeah, thank you for being here. But we have a question from,
Trach patients, Tremaine, do you mean, are these open to air trach patients or are these patients who are ventilator dependent?
No, Ben.
No, thank you.
I know you're different. I know you're relieved.
So you were having a heart attack over here.
Okay, we do have a question online as well from Martha. Who supervises the care provided by visiting medical professionals, including nurse professionals and specialists? What action may a family caregiver take if an issue arises?
Um, so we have our clinical team, director of nursing, unit managers, clinical consultants. So what happens each day is we go and look at the prior day, anything that's happened in the last 24 hours, medication changes, diagnosis changes, any change in behavior that's reported from like a CNA or a nurse. Maybe a resident hasn't had a bowel movement in 3 days. So we look at all those clinical processes and then we try to establish interventions. We have the physician that's on site. So the physicians that are on site are overseen by the medical director and their director. And then we also have medical directors that audit each patient for physician visits, ensuring that their H&P is done timely, ensuring that orders are signed, ensuring a lot of the compliance with medical records oversees that aspect too. So it's a collaboration of the clinical team, medical records, and then consultants as well. And then the second part of the question, if a family member has any issues, they can always email, call, or just walk to my office. And then if there's something that, let's say it's clinical, I'll take the concern, but I'll communicate it with my director of nursing and then work on an action plan on how to address it.
Trey, do you have like a community open house? Because like you said, seeing and talking to yourself and your staff is important. And otherwise people just see what's on the internet. Do you have an open house that you do?
We don't have an open house, but I do like the idea.
Yeah.
I think the closest thing we had to community engagement was our end of summer cookout. Had it for the second year in a row. And we had family, friends, all invited residents. We have it right outside our rehab gym. This year we expanded to the parking lot. So I know we have a really small parking lot, but we did block off about 10 parking spaces. So we had lots of families that came, lots of residents. We had music. We had food, like a lot of staff served. So it's been a big hit last year. And then this year, I think it was even better. So I think next year we won't do it again because it's going to be an annual thing. It's just expanded that a little further, but I do like the idea of like a community open house.
Yeah.
Maybe
Thanks so
that's-
much for being here.
Maybe that's something the community advisory board can help to.
Right.
promote.
Yeah. So yeah, thank you both for your time and giving us really in-depth information and just for engaging with us. So that's really great. Do we have any other questions or comments? Erica?
Yeah, I wondered, do you have any communication with the other nursing homes in the county? Do you ever like exchange practices or information, and do you see that as a good thing, or, how does that work?
I don't have contact with every facility, but there are a few that I do have contact with. One of the things we will look at is like wages to see if like we are comparable to other facilities or if our wages are low or higher than other facilities. So I think that's something that happens quite a bit. And it's just like wage analysis because we're all fighting for the same staff. I think that's an important thing, the culture part. Because if you're working at a place that you really enjoy, you're more likely to stay at that place or go to that place if you hear about the company culture. But, you know, going somewhere right now where you get, you know, $3 more, that may change a person's mind based on what the culture is. So I think culture is that extraneous variable that I'm trying to work on with our facility to improve.
Is there a pipeline or something where you have apprentices either from community colleges that provide a pipeline of employees? Is there something like that in the county or in the state?
So we're working on getting more partnerships with schools. We do have one partnership right now. Sort of standard college, but we're trying to get more in like Northern Virginia, so that we can go and actually do mock interviews with the staff that are there, give them expertise, or they can have Q&A of what happens in the facility and some of those type of things. I was successful with having something similar in one of the Illinois, but I do think that would be something where it's not will be. That's something that we are trying to encourage and garner as some additional schools where we can't have a pipeline where you know, the more you know, the more informed you are with making decisions.
Yeah, absolutely.
Can I mention one resource?
Charles, please.
So one resource I want to make sure you're aware of is one of the hats I wear is as a SHIP counselor in the VICAP program, which is the Medicare counseling program. And one of the things that we're seeing, and SHIP counselors are seeing nationwide, is managed care programs under Medicare being quick to deny continuing rehab. And I know you do a lot of rehab, so that may be a thing you run into. And, you know, keep in mind that we can help people fight those insurance companies if that happens.
That's a great point. The Medicare Advantage plans, I think our average right now is about 17 days, 17, 18, which is the start contract from a traditional insurance. It's at least 12 days. I'm sorry. Yeah, at least 12 days that's going on, but you know, we can't advise someone to like disenroll, do those things. That came from like the advisory board that helped out, or but there are perks to those plans too, where I think sometimes we look at just a nursing home component, where in the community, someone where Kaiser, they can just go and have all their doctors in one spot, one place, and there's some benefits there. But the managed insurance is that the challenge our nursing homes is no one expects to be in a nursing home, and once you're there, you're expecting to have a benefit. That's up to 100 days, and then there's someone that's managing it, and you know, you feel like there's still more progress to be made, and then you get a notice that you're discharging. So we do help with like the appeals to ensure that we have the appropriate documentation and also advocate for why we think that a patient may need additional time, but that is a challenge.
That's you.
This is Claire. I'm on the phone. Can I ask a question when everybody else has asked their questions?
Just-
Thank you.
Just a really quick one, Claire, because we do need to move along, okay?
Okay, all right. Anthony, Tremaine, I wanted to, this is Claire Jacobson. I'm on the phone. We've met. I was there a couple of times at the end of July. I'm Claire Jacobson. As we said, I'm the other Claire. There's also Claire Yeomans from the Ombudsman Program. I wanted to get back to you quickly about the percentage of Medicaid beds for the long-term patients or the long-term residents. Did you say it was the percentage of Medicaid beds for long-term residents? Is it, did you say 66%?
No, I just did the calculation, actually 69%.
Okay, it's 69%. Okay. Do you have, in the long-term care group, do you have any residents who are actually private pay?
You have private pay.
Yes, private pay, like a traditional private pay.
Yes, traditional private pay, a long-term care, a long-term resident who is not part of the 69% of the Medicaid assignment, but pays privately
Yeah.
out of their own funds. Do you have any of those, or is there a percentage of that?
I have to pull that percentage, but we do also have that. That's not included in the 69%.
Okay, but I'm talking about private pay for long-term resident. I'm not talking about the short-term rehab. I'm talking about those who are there most likely indefinitely. So you do have
Yeah.
a few of those.
We do have a few of those. Because the private pay, like what I consider on our metrics is someone that's paying the stay in the facility long-term care. So we don't have, like, we may have someone that pays, their insurance. As Charlie discussed, may had issued them a last cover day of Friday, and they want to pay until Monday to stay, and that'd be considered private pay, but that's not included in this figure.
Oh, okay, all right, okay. Thank you. I just want to. So, roughly, since you have, let's say, I'm going to say 30% of Medicaid beds. I mean, 70%. So the other 30% are individuals there for what I call short-term rehabs. The infamous Medicare 21 days or longer. That the other 31% or so covers those who are there under Medicare payments for short-term rehab. Am I correct in my interpretation?
That's correct, but the private pay is included in that figure also.
Also, and the 31%. Okay, all right. And then one real quick question. 'Cause Helen, I need-
Claire, yeah,
Yes.
we're gonna have to move on because we have a full schedule here today, so.
Okay, all right. Thank you. I'll catch up with Tremaine because I just live down the road from Cherrydale, and I pop by, occasionally. So thank you for allowing me to ask for that clarification. Thank you.
All right, thank you so much. Thank you, Tremaine, Manny, for coming today, and appreciate it. Please come back as well.
Thank you.
Ellen, area plan submissions, and then we will see if we need to take a break, but you want to dive on with the area plan submission before taking a break? Or
It's up to the group.
does anyone need a break? If so, let's take a 5-minute. I think we're ready to move on.
Ready to roll on. Keep charging forward. All right, so.
But if you do need to, please go ahead individually.
Thank you for having me today.
Yeah, thank you all very much.
Okay, so for everybody online, are you seeing the slideshow okay?
Yes, we can
Yes.
see.
Yes, thank you.
Thank you, appreciate that. So I'm not able to see anybody or see anybody raising their hand, so I'll go through the presentation quickly and then I'll stop sharing my screen and we'll have, if there's any questions after that, okay? So back in July, I mentioned that we had received our allocation for our area plan, and that I would come back with our submission for the federal fiscal year 2025, which begins October 1st. So that's what the intention of this presentation is. So we'll go through the area plan, what I submitted to the state. We'll look at some of our trends and needs, and then we'll talk about some next steps. So first question of developing the area plan, kind of what goes into it? How do I decide where to put the funds, the allocation that the state sends to me? So looking at some really key things. So first of all, what are the required services? And we'll go through that in a slide I have for that. Then I take a look at how much did we deliver in the last year and what am I projecting in those key programs for the upcoming year, maybe even the next couple of years. We all know that the cost of everything has been going up. The cost of meals for our home delivered meals, for example, went up roughly 3%, transportation the same. So factoring those, that into our projections, right? How much can we afford with the money that we have? And then what are the allowable funding sources that I can use, right? Some of them are open. I can use use this funding source for a variety of programs. Others are very restricted. NSIP being one of them, I can only use that for meals. Whereas one of the funding sources like the Title III-B, I can use for a variety of different things. And then there are some other requirements with matching. Is the state allocation an equivalent allocation to the federal funding? Do I have some local match in there? So there's a lot of different things that go into developing the area plan that we then submit to the state. So for federal fiscal year 2025, these were my allocations. And on the surface, and I think I mentioned this back in July, it looks like we've got a 7% increase in our funds for the fiscal year. What that doesn't take into account is that ARPA funds expire at the end of September. So if I look at my allocation at the beginning of this fiscal year and compare it to this total allocation of $1,040,000 roughly, it's actually a 20% reduction in funds that I have to spend for federal fiscal year 2025. On a good news note, we were once again allowed to have unlimited carryover for the Older Americans Act funds. So the Title III-B, the Title C1 and C2, and the Title III-D funds. There was some leftover, and I estimated roughly $179,000 that I could carry over into the new fiscal year. But that was an estimate back in July. We don't know the real picture until we've done all of our submissions in September. Okay. And then the other note that I have on here is these are the allocations after the allowable transfers. So I am allowed to transfer a certain percentage from Title C1 to Title C2, for example. And I actually maximized that this year to make sure that I'm still concerned about having enough funds for home delivered meals, but we'll talk about that in a minute. And normally we take that allocation that we can transfer from C1. We can transfer it either to C2 or to Title III-B. And normally we do both. But this year, I am only transferring the maximum to Title C2, just to be able to maximize that amount of transfer, okay? And then I know we talked in July a little bit about it. We were surprised by a fairly significant cut in our NSIP funds, and that's funding that is allocated specifically for meals, for our home delivered meals program, and I believe we can do some congregate with that as well. But this is a federal program. The federal government has instituted this significant cut to this program, and so therefore it gets passed down onto the agencies on aging. Okay. All right, so I talked a little bit about required services. And so the top table is the list of current required services. So CREA is the information and referral. That's primarily our Aging and Disability Resource Center. We're required to offer some level of care coordination, options counseling, congregate and home delivered meals, nutrition education and nutrition counseling, transportation programs, disease prevention and health promotion, legal assistance, elder abuse prevention, and the ombudsman program, and then VICAP. Okay. Starting October 1st, 2025, there are also a number of caregiver programs that we're going to be required to implement. Okay. And so we're looking at those now and making sure that we'll be ready and have something in place by October 1st of 2025.
Do you know yet how much additional funding you'll get for those required new?
If I have to guess, 0. That's been the issue with a lot of these required programs. Nutrition education and counseling, a very great example. What was it, 2-3 years ago they mandated it? And we got 4 years ago.
Yeah, we do experience a lot of unfunded mandates from the state. And we use some of the 3E money for the caregiver supports. We have been doing that, but we don't anticipate any increase or additional funding for the mandated services.
Right.
And that's coming from the federal government, right? And the states are putting it in place. I mean, in terms of the requirement, I mean, that's because of,
I think we don't have a lot of insight into
okay.
what comes from the federal government to the state and gets passed to us. So,
I think it's from the feds,
probably. Okay.
I can find out, yeah.
Okay, so this is just a graphic view of what programs we do offer in Arlington. I will send these slides out to you, so, you know, you don't have to try and read the eye chart. It is pretty small. I apologize for that. So this here then is just a really high level look at how I have allocated my area plan submission, right? So looking at how much from the Federal Older Americans Act, how much from other federal sources, so that being NSIP, and then how much from the general funds. What I haven't included in here is the local match amounts. And so, you know, that could be for a deeper discussion at another time. But this just basically, the allocation that they gave me here is how I have spread it out across the programs, okay? So within our homemaker program, 167,000, 168,000 roughly from the Older Americans Act funds, primarily Title 3B, and then another 71 from the state funds. Okay. Our Aging and Disability Resource Center, almost 91,000 from the federal and just over 96 from the state funds. Transportation programs, split between, again, the federal and the state funds, more from the state than from the federal. Congregate nutrition, and this is not just our social 60 plus cafes, but also the meals at the adult day program. Okay. 70, almost 80,000 from the Older Americans Act, and then another 27 from the general funds. The home delivered meals, we have roughly 280,000 from the federal, 31,000 is the NSIP funds, and then another 90,000+ from the state funds. I'm pulling the nutrition counseling and education all from the federal funds. And then the disease prevention and health promotion is all Title 3D. Okay. And then looking at the other programs that we do. So, we have a money management program, very small program, and that's all from the federal funds. We allocate a little bit for outreach, so that's things like our community engagement forum. If there's any materials, brochures, things like that that we want to do, that comes out of the outreach. We're allocating $50,000 for legal services for individuals 60 and older. There's also a separate pot of money from Arlington County for those that are under 60, but that's not part of my submission. And then we get a very tiny amount for the long-term care ombudsman program. And that's primarily because Fairfax manages that program. And so that's part of our contribution that we give to them. But because we don't have the program itself here in Arlington, we get this teeny little amount of money for that program.
With additional local funding support.
Yes. There is local funding that gets added to that to meet our bill that
Right.
Fairfax sends to us.
Yeah.
Yeah, thank you. Offset is right.
Yeah.
Okay, and then the last group is the National Family Caregiver Support Program. And for this year, a majority of the funds that we receive for this will go into the caregiver counseling support training functions of the program. And then a little bit for the homemaker respite. So homemaker services to provide some relief to the caregivers. Okay. Okay, so we've talked a lot about some of the trends, but I just wanted to mention these here, right? The trends that we are seeing, and none of these are really surprises. The population of adults in Arlington who are 60 and older is increasing. Just over the last year, we've gone from 14% to 16%, and it does continue to rise. Program costs also rising. Again, that's no surprise. And then the request for services, both programs and assistance, right? So things like in-home services or financial assistance, those type of things, those are also increasing. And then I put out here also program requirements, and so that is these new required programs that we're gonna have to implement, probably unfunded mandates. Those are also increasing. Every year, we seem to get a new set of 5 to 10 programs that we have to do, right? So what's not changing, it's our funding and our staffing, right? Those have been fairly consistent, right? So, so
We're still here.
Yeah,
We're still here.
so looking at the needs column, right, obviously additional staffing would really help out, right? And specifically in our Aging and Disability Resource Center, we have a temporary eviction prevention specialist right now through the Benefits Enrollment Center grant. We would really love to make that a permanent position, because again, the number of unhoused older adults is increasing, right? And then also in our adult protective services. Another thing, so I've mentioned a couple times our Meals on Wheels program, our home delivered meals. I'm concerned about being able to serve everybody who needs to have meals, right? Traditionally, we have never utilized any local funding for home delivered meals. It has always been funded through the Older Americans Act funding that we get through the state. So for the first time this year, we may have to ask for some local funds to support, to continue to be able to provide meals to people who are homebound, right? And then the other thing is shelter space that's appropriate for unhoused older adults. Kasha can attest to it. We probably have daily conversations with her. Can you take this person? And a lot of times the shelters that we have just are not appropriate to support some of our older adults. And so those are the big needs that I see.
Regarding the home delivered meal and local
Yeah,
funding,
yeah.
Ellen, could you give us an idea of the magnitude? Is it 10,000, 100,000?
My projection right now, I'm thinking is somewhere between probably, pulling this from memory, right? But somewhere between 50 and 100,000,
Okay.
right, is where we are.
Is there a likelihood of that being funded? Do we know?
Well, with
I think, I mean, we're definitely looking at the numbers and we'll talk a little bit about budget requests
Okay.
in just a moment, but I think looking at the projections, we do have other programs like our community living program where we've had people on the interest list, and I think that speaks to the presentation as well, is that the demand and the increase in services is increasing, and we work closely with Meals on Wheels of Arlington. They have really amped up their efforts in fundraising, and some of that, the work that they do also helps us serve those who are under 60. Because one of the program requirements for the federal and state funds is that we can only serve residents 60 and above. And so we do have a partnership with Meals on Wheels of Arlington, but I think that this is for the area plan. We'll definitely share more about sort of the budget and some of those needs and more specifics soon.
Yeah, thank you. Because, when we have engagements with the board, there's something that we could advocate for. So just want to get an idea. Thank you.
Yeah, Kasha.
Just a quick question on the Meals on Wheels. Is there a portion that the recipient is responsible for?
So depending on their income level, okay, we can ask them to make a contribution.
Okay.
Individuals who are at the higher income brackets, right, they are private pay for home delivered meals, right? But individuals that we would refer typically, right, they're what we call our Title III individuals, we ask them to consider a voluntary contribution, but the Older Americans Act prevents us from denying service for lack of ability to pay. So somebody who, maybe is up on the upper end of what we would consider for a subsidy, right? And we're asking them to pay $15 a week, for example. If they're not able to pay that, we're still going to take meals to them. Okay.
And we do have a sliding fee scale. The other thing I wanted to mention too with trends is it's also the quality of service. I think we really do pride ourselves on providing high quality service. And I think one of the reasons, we have had a vendor in the past that really contributed to the fact that we never were hitting our budget or exceeding what we allocated. The fact that we do have a pretty high quality vendor, we have more people who are interested in the program and then stay on the program for a longer period of time, which also
contributes not just to the need, but the quality of the food that's being offered as well. So I guess it's kind of a good problem to have, but it's still one of the things that we are facing.
And with the 14% to now 16%, you can see that over time, the demand is going to grow even more because we're going to have a growing demographic of older adults who are living longer and want to stay in their homes. Right. Thank you.
Okay, so this is my last slide. So, so the question similar to what's already being asked, how can I help, right? So, first of all, the county fiscal year 26 budget season is about to kick off, right? As hard as it is to believe, we've only just started our current fiscal year, the budget season's coming, right? So I actually looked at the schedule from last year, and it was roughly late October, early November that the county manager started asking for input from the community, right? So we'll make sure to send that out when that comes out, but make your voice heard, right? Tell the county manager to pour some more money into older adults in the community. In February, he releases his proposed budget, and then March is the county board work sessions, and then April public hearings, and then at the county board meeting in April is when they adopt the next budget. So that's just really rough schedule, but there will be things, that if you want to be advocating for the older adults, certainly can give you some ideas. Our community engagement forum is right around the corner. Hard to believe, but March will be here before we know it. So I have planned a kickoff meeting for the planning of it on Thursday, October 17th at 9:30. If you are interested in helping out, let me know. I would love to have as many people helping me brainstorm the ideas. I talked about some ideas for changes to the community engagement forum when I talked in May. So if you want to be part of that planning, let me know. I'm happy to add you to the invite. And then there's always NBAN, right? So we have the NBAN breakfast is on Friday. Where we will be releasing the platform to our delegates and senators. And then that will kick off a series of individual meetings, the NBAM members, the commissioners meeting with our local delegates and senators. And so advocating for those 6 items, but also, doing some education of the population is growing and some of the things that we're seeing in Arlington as well while you're promoting that agenda. And then in April, we'll start that process all over again of brainstorming ideas for the platform and then voting on the next platform. So those are just 3 real high level ideas on how you can help and, 3 sort of big areas. So, all right, I'm going to stop sharing my screen now so I can see everybody else once again.
All right. So thank you, Helen.
Any questions for me?
Exactly. Charlie.
Helen, one of the earlier slides showed a federal 3B allocation for legal assistance at $50,000.
Yes.
What do we get for that?
So that's Legal Services of Northern Virginia and the support that they provide to us. They do a lot of eviction prevention. That's all specifically elder law type activities, but they're doing eviction prevention work, helping the adults 60 and older avoid eviction, hopefully. They do some wills and guardianships. They'll do some
POA.
POAs. Yeah.
Guardianship.
What can't some of the other?
No, they do a wide range of service. So they'll do wills, power of attorney. They'll help with disability applications and provide some advocacy and support there. They'll help with some bankruptcy, nursing home discharge appeals they'll help with. They do outreach presentations in the community. They have helped with Plan Elder Law Day in the past, and that was an event. But the funding that we allocate is mostly for adults 60 and above so that there's no charge. And even if somebody did have, they don't charge for the service, but if somebody does have resources and reaches out and says, hey, I have $1 million I want to put in a trust, legal services in Northern Virginia will refer them to a reputable attorney to help guide them through that process. They do not help with immigration because of the federal funding. They are prohibited from doing that. They don't help with any criminal matters either, and they don't do domestic violence. But pretty much everything else they're willing to offer.
Did you mention a local allocation for legal services for those under 60?
Yes.
What does that do?
So primarily that has been eviction support and prevention. They have an internal team and again, it had been a little expanded prior to COVID, but they review the eviction docket when it comes in every week, identify individuals who might need some additional support. They'll go to court with the person.
Who does that?
Legal services. They have a whole little table set up at the courthouse and try to connect people to either keep the eviction off their record or prevent it, or if they are evicted, refer them to us or the first floor economic independence to help with some advocacy and getting rehoused.
Okay, thank you.
All right, thank you. So, oh, go ahead, Kathy.
Send over the slides. Is there a way for you to mark specifically like what the ask of the county board is for funding so that we understand? It might have been on there, on your slides and some of the tables, but to better understand, you know, what we're asking the county board for. I know generally we could say aging services, but
Yeah.
be more specific.
So what I have on the slides is just specifically our allocation through the state, right? So I didn't include any of the Delta, right?
Yeah.
But that's certainly something that we could provide.
Yeah, just
in the
curious.
future.
Okay.
Yeah.
All right. And then I had a question, maybe I misunderstood, but you said you had like, was it over 100,000 left over from, that you're anticipating to be left over to carry over
Yes.
for, and why was that money not spent? Was it primarily staffing?
No, I
Staffing?
think it's primarily because of the extra funding that we had from ARPA. Right, we had a
Right.
really big allocation of that, right? So, so we didn't spend all of our Title III funding because we wanted to spend that ARPA funding first. Okay,
Got it.
so,
Okay.
I do not anticipate going forward, we'll be needing to ask for any
Yeah,
carry.
for sure. Yeah.
Yeah,
And you have to use those dollars for what they originally,
yes,
yes, the original purpose.
Yeah.
Hey, did I see a hand? Is it?
I was just gonna ask a quick question. I know you mentioned the county manager. So are the plans to meet the county manager first and county board members afterward to provide input on budget requests or have you thought that?
well, no, so what I was really referencing, and the county manager generally asks in the fall for input, right? There's some sort of online community engagement where he's asking, what are the priorities? So it goes out on the webpage, right? So before we get to that step, we'll develop, you know, a list of asks that we can ask you all to send in, if that's, yeah. So.
Super. All right. Thank you very much. We got packed agenda. So we're gonna run through these pretty quickly. So still pending are the postcards from the future, election. We got meeting minutes, staff reports, chair's report, committee and work group updates, liaison updates. So we're gonna move through these pretty quickly. Regarding the postcards from the future, that's one of Libby's initiatives. So what do we want the county to look like in 2050? So please search for that on the website and submit those. I mean, we have our age-friendly plan, so we have our priorities pretty much set up. But please submit any ideas that you may have.
I'll include a link to that in the follow-up materials that I sent out, but yeah.
Super. So the nomination, election of the chair and vice chair,
So my understanding is, who does the official nominating?
executive committee, right?
Executive committee,
Yes.
yes, okay.
Since you both are on it. Would anyone else?
We'd like to nominate William to chair and Kathy to co-chair.
Great. And
Vice chair.
vice, okay, great, vice chair, All right, and should we just take the vote, at this point?
It's a vote for chair at this point. So the nominee on the table is William Way. Any other candidates wanting to step in for chair, do a quick debate?
All right, so,
Not seeing none, so can, all in favor? Say aye. Any opposed? So that's, congratulations, William. And the same process for vice chair. Is there, so we have the nomination. Any other candidates want to come forward? Seeing none, anyone, all in favor?
Aye.
Okay, any opposed? Okay, congratulations, Kathy.
thank you all so much for your trust and confidence in Kathy and myself, and we promise to keep doing a good job. All right, next, approval of the July and August minutes. Did we circulate
We
those?
did, yep.
Okay.
Yep.
Do we have any amendments? Any
Starting with July.
revisions with July? Let's start with July. Seeing none, and we'll just vote for them.
No, I just had like
Go ahead.
minor edits that we have to
You
say.
can just say
That's it.
Yeah. How about regarding August? Any edits, revisions? Okay, seeing
Well
none.
done.
Okay. And so let's go to the approval. Do we have any motion for approval of both July and August meeting minutes? Okay.
Second.
Motion and seconded, and all in favor?
Aye.
All opposed? All right, the meeting minutes are approved. Next, staff reports. Helen, Agency on Aging, do you have any
I
other
have.
updates?
Just a couple quick things, and I promise I will be quick. So first of all, very exciting, our new AAA nutritionist starts tomorrow. So I'm very excited. Alana Sullivan is an Arlington County resident. She's fairly newly minted, registered dietitian, but very excited to come and serve the older adults, especially the older adults of our community. So I will look to bring her to a future commission meeting so you can all meet her. She will be part-time, 3 days a week, and her activities will be nutrition counseling and education, menu reviews for our nutrition programs, and other nutrition-related activities. So really excited. And can't let that announcement go without saying a really big thank you to Anna Caballero. Anna is been with us for 9 years, I believe. She is a public health employee, dietitian with the WIC program, but decided that she wanted to help us out 6 hours a week. She has been very faithful. I know the participants in the program are really going to be sad to know that she's leaving because they all love her to death. But she will be missed by all of us. She will be transitioning off at the beginning of October. So we also have 2 social work interns in the Agency on Aging this year. Sarah is with us in the back corner, Sarah Malala. So she's going to be supporting the Agency on Aging and the Benefits Enrollment Center. And then Calvin Johnson is going to be supporting the Aging and Disability Resource Center. So Sarah is a VCU social work student and Calvin is at George Mason. So welcome to them both. And then we're continuing the recruitment activities for a human services clinician too in the Aging and Disability Resource Center. So hopefully, fingers crossed, that will continue to go well and we'll have somebody to announce next month. So in the Aging and Disability Resource Center, of course, we continue to talk about the increase in demand and both with the phone calls and with the walk-ins. We have onboarded a couple temporary staff to help ease the burden. We have a third one in the works, but we also, effective September 1st, started limiting the walk-ins on Fridays. Okay. Primarily to give the staff time to catch up on their administrative duties, the notes, things like that. We will still continue to see emergency cases. So like shelter, somebody who is unhoused, somebody who has no food. And somebody whose utilities have been cut off. We will still have staff on site and we will see and serve those individuals. But everything else, we have packets of information that they can complete and leave with us, and then they will be assigned to a worker next week to give them a call and set them up with the services that they meant for. Okay. And I really want to give a big shout out to Tanae Young, who is our interim ADRC supervisor. It's her advocacy for the team and her creativity that has allowed us to take this step. So kudos to you, Tanae. Thank you for your hard work. Our senior loop contract, we've talked about that quite a bit. We did finally get that awarded 2 weeks ago. Okay. And I'm happy to say that Diamond Transportation will continue to be our service provider. There will be some changes to the service. So over the next couple weeks, I will be working with them and then communicating out the changes to the program going forward. So more to come on that. Also looking at the contracted services, we got a call from Jeffries last week. They have had a really rough 2024 and it continues, right? They had some issues, they had their fire suppression equipment inspected. There was some issues with it, so they cannot prepare hot meals until they get that addressed. So they will be sending cold meals out to our home delivered meals, to our congregate sites, to adult day, to the shelter, everyone that's on the contract. And this affects not only Arlington, but Alexandria and Fairfax as well. So I'm sure they're going to be really happy to have.
What happened earlier?
Well, they had the fire, they had the big fire, right, that has forced them into this temporary location, and now, you know, there's this issue, so they're gonna be really happy to see 2024 go after. Let's see, and the only other thing that I have is Medicare open enrollment season is right around the corner. It kicks off October 15th. And so the VICAP team, including Charlie, and I see Mike Schuster online, two of our great volunteers in our VICAP program, they're all getting ready. Right, and so Michelle Thomas, the VICAP coordinator, is doing trainings and making sure that everybody is well equipped to what they need to know about changes to Medicare for the upcoming season. So that is it for me. We'll pass the baton to Rachel. Yeah.
Good morning, everyone. I will try to be very brief. But just wanted to give an update. Our adult day program is hosting an open house. We'll send a copy of that with the meeting follow-up. But if you've not had a chance to visit the Adult Day Center over at Walter Reed Community Center, it's just an absolutely phenomenal program, a great resource. Staff there are absolutely amazing. And at the state level, Adult Days have been, their official name has changed from Adult Day Care Center to Adult Day Center. So big change. But we will send around the open house for Adult Day, and there continues to be a pretty extensive interest list. Last year, we had a vendor do a study about Adult Day and potential expansion of not just Arlington Adult Day, but Adult Day programs in the county. And so we may look to invite Michael, the director at Adult Day, and then the team that did the study of maybe doing a presentation to the commission.
When's the open house?
Let me get that. I think it's October 17th, but I should have had that. Yes, I will pull that up and tell you. Thank you, Chuck.
Go ahead and I'll look it up.
Next thing
I
is,
just want to mention, I had the pleasure of volunteering with one of the staff from the Adult Day Center during the Arlington Fair. And she is so passionate about the work that she did. I loved chatting with her, and I said, oh, you need to come and speak to the Commission on Aging. So glad that.
oh, yes.
Yeah,
Was it
that you're
Jessica?
thinking along the same, I think it was. Yeah.
Okay.
Yeah,
Uh,
yeah.
And it's September 20th from 1 to 3:30,
Right after the unpaid breakfast.
right after the end band breakfast.
Yeah.
We'll all go to Adult Day. But there'll be a presentation from RAT, dementia specialist, some exercise, seated volleyball. I'm very excited about. And so just adaptive music, but again, it's just a great way to see the program. The staff are so passionate, and it's impossible not to walk out of there feeling such joy and just happiness. Our Adult and Protective Services team is fully staffed. Hallelujah. But we have some staff out on FML, on leave, and others who are going out. So just like the Aging Disability Resource Center, we have some temporary staff who've been lending support because they are also experiencing such a growing need. We've talked a lot about just the need for services, and one of the ways that we're hoping to address it is we applied and were selected as a benefits enrollment center. We are having a kickoff meeting on Thursday, September 19th. Our staff have been doing applications and helping people connect to benefits programs. We brought on a homeless prevention specialist, so people don't have to choose between rent and medications or food. And so if you are interested, I think we have about 60 people who are planning to join us. But staff, volunteers, our hope is to be in the community, helping people apply for benefits and services. So please let me know and I'll send you the invitation if you don't already have it.
Is that new?
It's a new grant, yes, and so we're doing more coordinated efforts to help connect people to benefits. But we know, I mean, just one example, we have about 14% of Arlington's older adults are in poverty, but only 6% are connected to SNAP food stamps. So we know that there is a need, and we're hoping through this that we'll have more of targeted outreach and support to connect individuals to benefits that they qualify for. We work with an organization within the county called Project Peace, and sadly, one of the things that we have been seeing is an increase in intimate partner violence experienced among older adults or to older adults. And so we worked with Project Peace to develop these brochures of just resources for supporting individuals who have or are experiencing intimate partner violence. We'll have, I don't think we've had Project Peace present to this group, but it might be worth having a presentation. They are hosting an event, I think on Wednesday, a community event about kind of their strategic plan for intimate partner violence. I plan to attend, as well as some of our staff from Adult Protective Services. And then just the last thing, I'm going to end on something fun. Brought some cupcakes, so I'm sorry to everyone who is joining virtually. But today is my husband's grandmother's 100th birthday. She's an amazing woman, and it reminds me, as we were celebrating her this past weekend, that in the past, we had hosted a centenarian celebration. Jennifer, Jessica, the team from Parks were such integral partners. And so I think it's time we do it again in 2025. And I don't know if Roland or Carlos are on the call, but I think we'll work with the outreach team. But it's been a great opportunity to celebrate Arlington centenarian. So we will do that again in 2025, but please have a cupcake and say happy birthday to Florence on your list. Thank you.
That's wonderful. Yes, that was so fun. And some of you were here to celebrate with us. So please, if you know your centenarian neighbors, let them know. We want to celebrate them in 2025. I just have one announcement because I know you all are running out of time. So I'm excited to share that we have a new RAFT program director. So RAFT is our regional older adults mental health facilities program. We can have her come once she's more settled, 2025, to report out. Dr. Bridget Whitehead is her name, and she brings 20 plus years of clinical experience and also leadership experience. Her last employer was the Wellness Recovery Center in Loudoun. So she came aboard on Monday of last week. So I'm going to head out shortly because we're having a lunch for her. But she's with us. So RAFT is now fully staffed. That's all I have. Thank you.
Great. Thank you, Maria. Thank you all for the great news of, you're getting great people on board. So that's so great. Better than the other way around, right?
Yeah.
So thank you so much. So I know that Catalina and Joan are heading out for their engagement at 11. Do you want to provide an update on your outreach before you go?
Yeah, sure. So I'll just give a couple quick updates. Like Will mentioned, Joan, Peggy, myself have been conducting outreach to the different Social 60 cafes in Arlington. So we started last Friday or the Friday before at Langston Brown's. And so we heard a lot of good feedback in general, also some great ideas about, bus stops that are too far from Love a Run, or, if I want to get to this event, I have to take a bus to a bus and I'm, traveling for a long time and it's not convenient. So we have a lot of good insights. We're gonna try to document all that and share it out maybe at the next meeting. So we have one today at Arlington Mill, and then next week we have one, the last one at Walter Reed. So hoping to get more good insights there. We're handing out these transportation booklets, which if you haven't seen them, just has a bunch of different services listed out. It's very easy to read and, people have really liked these, and we have Spanish versions too. So, Helen, if you could share a link in the.
Yeah, so it's available online on the website as well as, we have the hard copies, so I'll send a link to it.
Thank you. So that's the big update there. And then also someone from the Department of Environmental Services, Kristen Calkins, reached out about, having someone from our group join the advisory group for the transportation plan that they're putting together for the county's comprehensive plan. So I'm gonna be joining that and I'll help sort of coordinate and be a liaison between our group, share feedback as to what's happening there, and then also take all of our insights from the community and advocating for older adults in the comprehensive plan. So more to come on those.
Thank you all so much. Yeah. And it's great to get out there and get the input from the older adults themselves. And hopefully we have some suggestions from the older adults on how they want them to be addressed. And I think it's also a good opportunity for us to update the board as soon as, we get all these data points to let them know, hey, here's our age-friendly plan on transportation, and update them. So thank you so much for doing that. All right, so chair's report, I'll be very brief as well. As we said, collaboration, outreach, and advocacy, three-legged stool. So, it needs to be balanced if we want to be successful. So just focus on all three, please. Second item, year-end report card. So kind of think for yourself and your committee. What do I want my report card to look? We don't really have report cards. What do I want my year-end report card to look like? And now it's September, so you have September, October, November, and December. And so things that are on your age-friendly plan, try to work on the items so that at the end of the year, you have the report card that you want to share and the accomplishments. And mentioned that the third item is mentioned that the executive committee, if any of the committees want to update the board on your plan, please let me know. We will arrange for a time and we'll update them. Doesn't need to be anything fancy, any input you get from the public. My impression from the board is they want to know about your concerns before they become problems or before you even have solutions. Because, they want to have their ear to the ground on what the community is thinking. So that's it on my report. All right. So we're going to transition to aging and work group updates. Are Carlos, aging, equity, and engagement. Are Carlos or Roland, are you on? If not, I will just update from their report at the executive. They're not on. Okay. So they have a presentation at Aurora Hills on scams. I didn't note down the date.
That was last week.
Last week, okay. And the
Yeah, last Thursday, so.
Fantastic presentation.
Yeah, it's a big problem. Ambassadors program they had their first onboarding, 10 new applicants. I believe Charlie noted civic associations are a good source to brief to and see if there might be potential applicants from there. Carlos noted they need more ambassadors from the Latino community. He also mentioned an idea about online book club for older adults. And on October 28th, there's an LGBTQ event that Roland mentioned, but I don't have any further information on that. So that's from their perspective. Any questions? Okay. Legislative, Anthony, floor is yours.
Morning, everyone. We didn't meet as a legislative committee group last month, so we have no updates. But as I believe Helen mentioned, Friday is the NVAN breakfast. So look forward to, those items, 6 items being released and to the general, and moving forward in that process. So that's all from us.
Thank you, Anthony. All right, Charlie, long-term care? Any additional?
Well, I think you've heard enough.
No? Okay. Thanks for everything you're doing. And Catalina, you provided the update. Anything further? Oh, okay, I think we missed Joan. Joan, great. Health and wellness.
Real quickly, we met on September 6th and had a presentation that was very thorough and very helpful from two members of VHC, Jim Meehan and his associate Fran.
She's the director of case management, Fran Barnes, yeah.
Yeah, and talked about the discharge process, new plans that they're implementing to look at individuals and their ability to exist and take care of themselves once they get home, what follow-up they've got. They're looking at improving some of their survey information so that they can improve the work that they do. Anything you guys want to add to that?
Well, just as a little follow-up, so part of that discussion is looking at the systems within the hospital, of course, and one opportunity we may have is with our ED at the hospital. We're undergoing renovation there, and I haven't had a chance to talk to the committee members there. But it's just a nice opportunity for us to kind of get in the door and say, hey, can we even look at the physical environment, the way things are set up to be a little bit more geriatric friendly.
Wow.
So since that September 6th meeting, I've had contact with our CMO, Dr. Brian Stone, and he's very interested in that as well. So I'm hoping there's some progress we can make in that regard.
Excellent. It was a great meeting and they're implementing a lot of new best practices that look at social determinants of health and how individuals can cope and connecting those who are leaving the hospital with sources and resources and so on, everything from food to assistance in the home. So I was just really thrilled to hear these developments have been happening. We meet quarterly. Our next meeting is on December 6th at noon, location TBD. And Kathleen is going to provide the speaker who will talk about available evidence-based programs. That NCOA has a database, so we'll be able to take a look at this broad spectrum of things that we think are important.
Exciting. Okay, thank you. Housing and supportive services.
We have a routine meeting tomorrow afternoon at 3 o'clock upstairs. And then on October 8th, we have a speaker from Pennsylvania, NeighborWorks, talking about echoes and ADUs. If you want to know what an echo is, come to the meeting. That's October 8th, but that's an alternative housing option that they use in Pennsylvania. So she's going to talk about their successes with that. So that's going to be October 8th at 3 o'clock. So we'll be virtual if you want to see that.
Right, more housing and thinking creatively about it. That's super. Liaison updates. Do we have any liaison updates? Okay. Any old business? Seeing none. Any new business? Oh, okay. We have Jim stand up. You got our attention. Okay. Nothing there. Announcements. Do we have any announcements? Jim, please.
The Northern Virginia Dementia Care Consortium will have its 38th annual caregivers conference in Fairfax. And that's on Saturday, November the 2nd. Sponsors include AARP Virginia and Arlington County. For information and to register, go to nbdcc.com.
All right, thank you, Jim. NVAN is having their online meeting on the 17th. Arlington is the, I guess, the MC host. And Danya is,
Tanya Curry will do her reframing aging presentation in class.
and the breakfast is on September 20th. And Anthony, if you want to reach out to Helen, she has the ticket. All right, thank you all very much. And great seeing you. See you next month.
Helen, virtual next month? Yes.
That was a great presentation for long-term care. And you know, it's like a